it. Here's Richard. You can see, well, good morning, everybody. And guess what? Happy summer. Today is the longest day of the year. So hopefully everybody enjoys daylight until probably a little after 9 o'clock tonight, which I always enjoy. I don't really like the winter time when 4 o'clock and it's already dark out, but appreciate everybody taking time today to kind of listen to a very important topic. And I want to thank our healthcare steering committee for coming up with this topic. Today's topic is going to be about healthcare disparities and why it's important to employers. There's a lot going on, and you're going to hear from our distinguished panel. For example, we just talked before about how during COVID, about 15 million people were put on Medicaid to cover healthcare coverages. And so when we were talking about, well, what topic to cover, I was sharing an example where I went out to a member prospect. It was a small manufacturing company, about 15 employees. When I was talking to the HR director, she had told me that they don't provide the employees insurance, which I kind of was surprised, right? Because I think the majority, if not, I thought most employers provide healthcare insurance in one shape or form, right? Whether they get a stipend, they can go out and buy it on the Affordable Care Act websites, or they provide it through insurance. So we put together a panel, and I'm going to read their bios really quick, but the way this is going to work, just like we do at all of our events, we want to keep this conversational and informal. So please feel free as you hear the topics. Nice thing is we're going to hear from an insurer perspective, provider perspective, somebody who represents the pharmaceutical, so from a prescription drug perspective, and then we're going to have two attorneys that are going to basically back clean up, if you will, on some issues that you as employers need to know. So let me tee up. Paul Martin is the CEO of United Healthcare for Delaware, New Jersey, and Pennsylvania. He's also on our board, and Paul's going to give the insurer's perspective. Following Paul, we're going to hear from a provider. Very happy to have Deb Visconti, who's the CEO and president of Bergen Newbridge Medical Center. She's also a valued board member of CIANJ. Deb's been the CEO and president since 2017, so she's doing a lot on that front. And then we're going to hear from Dean Paranicus, who's the president and CEO of the Healthcare Institute of New Jersey. I've known Dean now for a long time, and before Dean was in charge of CIANJ, he was at BD. And his colleague Steve Eisenman is on. And then we have Grace Mack, who's co-chair of the health law team at Wilentz. She represents a client base, all healthcare physician groups. And then Nicole DiMaria, who's team leader of healthcare and hospital practice group at CSG. So without further delay, Paul, why don't you kick us off, and the floor is yours. Thank you, everybody.
Great, thank you. And I'm going to share my screen. And let me know if you can see it. Yeah. Should say using data to reduce health disparities.
Yeah, we can, Paul. Thanks.
Okay, let me see if I can get it. Okay, so just a little background. United Healthcare is the largest insurer in the country, and we've got over 700,000 residents of New Jersey carrying a United Healthcare card. And it's a mix of commercial members, that's businesses and individuals that buy insurance. And then we've got several hundred thousand in our Medicaid and Medicare businesses. And so it's broad in terms of the members that we serve. And I'm really glad that CIANJ decided to focus on health equity, because it is a critical issue to address. It's costing the country a lot of money in terms of members and just citizens who are not getting the health care that they need due to barriers. And it's pervasive, in Medicaid, Medicare, and also not many people really realize that it exists with our businesses. And I'm going to get into some of the data to level set on that, but United Healthcare has been committed to trying to address health equity by investing in a lot of different areas, from housing, investing in housing projects to serve those underserved, get them stable housing, healthcare, We're also investing in clinicians. We're trying to get a more diverse clinicians in the country because, quite frankly, the clinicians and people in healthcare don't look like the people that they serve, and that's critical to addressing health equity. So next slide. Apologies. But here's some of the numbers, but there is a huge correlation between income and barriers to getting healthcare, and referring to that as social determinants of health. It's can you afford to get care? It could be your living conditions. It could be the people that you're taking care of. There's a lot of different factors that contribute to, quite frankly, people dying and being sicker because of their socioeconomic condition. And it's the gap between those haves and have-nots continues to grow in the country. It's not getting closer, it's actually getting more intense. And those folks are in need. So bottom line is, CIANJ is, employer groups, and probably within your own businesses, about 60%, if you're like the national average, of your population could not afford an unexpected expense of $1,000. And if you kind of assess your current insurance plans, looking at the co-pays, deductibles, co-insurance, if anybody has any kind of significant health event, even moderate, you're probably looking at more than $1,000. And the reality is probably the majority of people that work at your company cannot afford that. And so because they can't afford it, they're at risk in terms of their health conditions really deteriorating further. And you can see some of the stats up here. It's income inequality, really for those that are on, below the poverty level or close to it. And even those who are the working poor have factors that make them more at risk for, being unhealthy. And you can see some of the stats here. Almost 20% are at risk of homelessness. A lot of people live with financial insecurity. We talked about that. 14% have high levels of food insecurity, and a third are at risk of social isolation. And so when we look at those factors, what you're seeing is people not getting care, and they're getting care in the emergency room, which is really expensive for everyone, including businesses who are paying insurance premiums, the government who's funding Medicare and Medicaid. And we believe that there's an opportunity to get people the care that they need prior to getting to the emergency room. So how can we do that? How can we assist them to get their preventive care, to go to the doctor when they need to, and they really require some assistance? And so if you look at this slide, basically more employers are becoming acutely aware of this issue. And it really depends upon the business and the demographic of your workforce. But we had a healthcare services client who really wanted to break down further the barriers that their lower income employees had in getting healthcare. And so when you look at this slide, the graph on the right, across the top going left to right, you have the lower income groups. They fed us their salary information, and we correlated that with their healthcare utilization. And so on the left-hand side, you can see the lower paid employees. And on the right-hand side are the higher income employees. And what you can really see is that income significantly impacts their healthcare consumption. And you can see that they don't get as much preventive care. They have literally 2.3 times the rate of emergency room use. They are using generic drugs far more often than those who have means. But the bottom line, as you can see, for the healthcare services and conditions listed just uniformly, there is less utilization and adherence for medical conditions, which just leads to higher costs down the road. And so we've got an issue, and employers are getting more curious about how do we address that, and we can talk about that later in the discussion. If I mentioned previously, 60% of adults couldn't afford an unexpected $1,000 expense. And you can see, again, some of the numbers here that high-risk individuals who you'd expect to have more claims don't. In fact, they've got less. So, in this set of numbers here, you've got members at low risk, moderate risk, and high risk. And the members who are at higher risk actually are spending similar amounts out of their pocket, meaning the benefit plan is costing them the same amount of money as those who are lower risk. But the high risk individuals actually have lower claims per head than the lower risk. Basically, the reason for that is those high risk individuals are not getting the care that they really need because of the barrier of the income. And so if you look at it by generation, millennials are at the highest risk for financial insecurity, followed by Gen X, and that's probably just where they are in their career and the types of jobs that they have. But it's a significant issue in that they're just unable to afford the care that they need. And so basically what we're trying to do is socialize all of the different impacts on that. And one area you might not think of is dental insurance, and not as publicized as health insurance, but dental is extremely important too. And the bottom line is that if people are not getting the preventive dental care that they need, especially in the example here is the diabetic population, that they are very likely to have their diabetes condition deteriorate at a much greater rate than those folks who are getting dental care. So it's just another data point to give you perspective that there's a lot of unmet needs for folks who have barriers to care. And it's not just medical, it's dental. And really the lack of adherence really leads to worse outcomes. And so you might be asking, okay, well, what are we doing about it? At United Healthcare, we are profiling our claims data. And what we're finding is that there's a significant amount of members who don't have any claims at all or very little. And we don't believe that all those folks are healthy. We believe that they've just got a barrier to getting their health care. And so what we're doing is we're mining our claim data for our insured population. Here in New York and New Jersey, we've got about 170,000 people where we've got no engagement with the health plan. And we're reaching out to those individuals to actually find out, do you have a social determinant of health or a barrier due to health equity issues? And if you would like to, we'd love to engage you with a community navigator who can help you get assistance so that you can actually get the care that you need, whether that's childcare, it could be assistance paying your bills. There's a lot of social resources out there. Aunt Bertha is a service that we connect members to, helps them get the assistance that they need, get them back on their feet so they actually have the ability to go get the care that they need. And so we're going to track this over time. We believe that what will happen is if we can engage a significant percentage of these members, there's actually going to be lower claims in the end. They're going to be more satisfied with their insurance plan. We believe that the ER utilization will eventually go down and we'll have less severe claims longer term. So we're trying to identify those folks who have barriers to healthcare and do something about it. And I thank Tony for having this forum. United Healthcare is acutely aware that there's something that we need to do. The data really backs up that folks who cannot afford to get healthcare are not getting it. And what we're trying to do is identify those folks, get them assistance, and help employers really identify who those folks are so that we can try to get them engaged in the healthcare system.
Thank you, Paul. And if you don't mind, and we could always come back to the slides. Yeah, thank you. Okay, Deb, welcome.
Thank you, Tony. But first of all, thank you, Tony and CIANJ team for putting this really vital conversation together for everyone today. And I appreciate being part of the conversation. And Paul, thanks for putting things into context and framing the issue with data. So Bergen Newbridge Medical Center, the largest hospital in the state of New Jersey. We have 1,070 beds under a 1 million square foot roof, sitting on 62 acres of Bergen County property. We are a safety net hospital, which you'll hear more about the way that ties into all the things that Paul just talked about. We are an equity anchored healthcare delivery system. And we follow our path, our strategy around our community health needs assessment and the needs of our community as it relates to healthcare. And a lot of what Paul just talked about in terms of equity and access and disparities in care, that's what we are focused on addressing at every level. And let me start by saying, we are only as healthy as our least healthy community member. And we should remember that as we talk about the rest of, the next, 45 minutes or so that we have together, how that impacts each and every one of us. And health equity, health access is everyone's business. So you might be interested to know that even if an individual has a employer-sponsored PPO plan, their out-of-pocket healthcare costs can be over $31,000 a year. That's for a typical family of four with insurance. So when you think about the communities that we're talking about, those who don't have insurance or don't have access to insurance, the costs are insurmountable, and access to delivery of those of the system becomes very cumbersome, and people tend not to get care. And when you think about what we do, we service everyone that walks through our doors, regardless of their ability to pay, regardless of their insurance status, regardless of their immigration status. That is the true definition of a safety net hospital. But the burden then falls upon the providers, right? So that we get $0 for individuals that have no insurance. Tony mentioned this earlier, during the public health emergency, millions and millions of people had access to Medicaid. So they had access to Medicaid. It didn't have to get recertified, revalidated every year. There's a whole application process for you to get Medicaid. If you don't have an employer-sponsored program, or if you don't have health insurance, Medicaid would be your payer of choice. And so during the public health emergency, people had Medicaid that didn't have to revalidate. But now that the public health emergency has ended, we're in what we're calling the unwinding process, which means that millions of people across the country, and in New Jersey, over 300,000 people are going to lose Medicaid coverage. They will have to reapply. And if they don't reapply, they automatically get knocked off. So there's going to be hundreds of thousands of people with potentially no insurance. So some of the things I mentioned earlier, that's happening here at the medical center from a provider perspective, and we are a unique provider because of our service lines, but also because of the fact that we're safety net. But the fact that we follow our community health needs assessment, what does our community need from us? How do we, to Paul's points, how do we deliver the care that they need when and where they need it? So we have to go beyond the walls of the hospital, right? So anybody, there's many hospitals in the state of New Jersey, 5 hospitals in Bergen County alone. People don't want to come to hospitals. They can't come to hospitals. They don't have the ability to get to a hospital. So what we're doing is we're going out into the communities to deliver care. Not only are we opening practices within various locations within the state, we're also partnered within Sarah supermarkets to open Care Right Now locations where people can actually get their healthcare delivered right when they're shopping for food. And so the way I looked at this and the way that, we've implemented the program is my first thought was, if you're a mother or a father or a caregiver of a family, and you can only leave the house once because you have children or elderly parents or whatever the case may be, you don't get out of work in time to go to the doctor. So if you have one trip out of the house, you get on that bus, you get in that cab, or you drive your car, you're going to prioritize food. You are not going to prioritize your health care. It just doesn't happen, right? You have to feed your family. So if you're going to buy food at ShopRite, you can actually access healthcare right there. We have primary care providers that deliver care. They do physicals, vaccines, anything that you need, strep tests, pregnancy tests, anything that you need right in your ShopRite supermarket. And that was really the vision. How do we reach those people that need care when and where they need it? Our community health program has grown in leaps and bounds over the last couple of years with the COVID pandemic. Our community health teams go out to communities of vulnerability where we know through COVID where those communities are. We reach out to them. We work with our communities of faith, our vulnerable communities, our religious leaders, and we say, where can we go to meet our communities where they need the care? And we go out with vans and we set up in schools and in churches and in YWCAs. We set up in parking lots, wherever the community needs us to go, we go to make sure that we can address their healthcare needs and assure that they have access to healthcare. Healthcare disparities, healthcare inequities, the rising cost of healthcare is not just my problem as a provider, it's everyone's problem. Because as Paul mentioned, people that don't go for their routine physicals or their routine screening tests or managing their chronic conditions like diabetes, hypertension, asthma, if you don't manage your chronic conditions, you're going to get really, really sick and you're going to end up in an emergency room. And there's nothing worse than an overcrowded emergency room, right, where you can't access our care because there's too many people in there, getting their asthma treated when they should have been doing that on a regular basis through their primary care doctors, right? So it's everyone's problem if we don't address, recognize, identify the disparate care that we're providing here in the country. Certainly in New Jersey, we're not immune to that. So from a provider perspective, what else can I share with you? We are already starting to see an exacerbation of certain chronic conditions. We are starting to see increases in mortality and morbidity throughout the system, throughout the healthcare region. The other thing we don't want to lose sight of is mental health. And one thing that we've seen for certain is that there has been a double-digit exacerbation of individuals with mental health conditions, possibly because of the pandemic. But I do believe that these are issues that have been in our communities, but now people are more able to communicate and to look for help. But this is something that as employers, as a community, as healthcare providers, we need to understand and recognize that there is no health without mental health. Individuals that suffer from mental health conditions tend not to seek care, tend not to take care of themselves. And, that has a burden on all of us, not just from a cost perspective, but from an access perspective. And for the employer community, your employees, they are going to lose time at work. You lose productivity. You lose the ability to run your businesses. So I will leave you with the comment that I started with, which is we are only as healthy as our least healthy community members. So thank you for the time.
Yeah, thank you, Deb. So now we're going to hear from Dean Paranikis on the pharmaceutical. Again, he runs the Healthcare Institute of New Jersey. And Dean, by the way, happy birthday today. So
Thank you very much.
his birthday. So happy
Happy
birthday.
birthday, Dean.
Thank you. So, I'm a very lucky guy in one sense because I get a gift every 6 months. The problem is my gift now is combined with Father's Day, and my gift at Christmas is combined with Christmas. But in any event, I'm delighted to be here. And of course, everything that you've heard already from Paul and Deb are, we're another facet of that stone because we're all, as the saying goes, in this together. And the side of that we represent, and my organization represents the research-based biopharmaceutical and medical technology companies in New Jersey. So you're talking about the major players: Bristol Myers Squibb, Merck, Pfizer, Novartis, et cetera. My alma mater, BD, and Stryker on the med tech side, et cetera. And of course, when you look at that, to echo what you've already heard, and it's not surprising, the twin pillars of access and adherence are essential as well, because for all of the unbelievable and amazing things that our industry has developed, and particularly just drawing most recently, for example, on the vaccines and the treatments that reduce the impact of COVID, none of that is worth anything if patients don't have the ability to access it. Okay, and so at its core, that's one of the things we do. And as a result, when we can get to patients and our products reach them, it's a huge part of the preventative and wellness equation. Because even though we're only 10%, represent 10% of the healthcare dollar, which has been the case since I think the 60s, we're a big part of that cost avoidance structure. There's a couple of metrics here that I think are worth talking about to pick up on what you heard already. That medication adherence costs the healthcare system about $330 billion annually in unnecessary medical expenses, as was estimated by Express Scripts a few years ago. If people just took their meds the way they were prescribed, and we're all in the business of trying to encourage adherence, that would save our system $100 to $300 billion annually. And this other metric always strikes me. There are about 187 million Americans who take one or more prescription medications. It's estimated that up to 1/2 of them don't take their medications as prescribed, and more than 1 in 5 don't even fill the prescriptions. So there's a whole range of reasons for this, but imagine we can develop the most extraordinary advances. And by the way, as far as this is concerned, this dynamic is not limited strictly to the branded side of the house that we represent, but obviously it also impacts generics and biosimilars, because if patients simply aren't pursuing their drugs. Harkening back to the sociocultural comments that Paul and Deb have already made, for example, you'll recall during COVID, the uptake on people being willing to be vaccinated was profoundly impacted by cultural barriers and a lot of reservations that had deep historical roots. Those are the kinds of things that all of us in this enterprise are trying to reduce and address, and our companies are heavily involved in this. And in fact, I'm going to ask my colleague Steve, as I'm speaking here, to put in the chat box a link to a comprehensive study that the National Trade Pharma, PHRMA, he just put it up. Thank you, Steve. Speaks to all of the things, both in terms of time, money, and effort that our industry is putting into this, but it's a critical area. And in the meantime, we talk about the fact that patients either can't afford their out-of-pocket costs or are completely losing their Medicaid coverage. In fact, virtually every pharma and biotech company has established for a very long time a patient assistance program that are designed to offer medicines at a discounted price or free to patients who can't afford them, either because they don't qualify for insurance or that even with insurance they can't cover it. Pharma, the national trade I just mentioned, has created a search engine called the Medical Assistance Tool, and that it's a portal, and it contains information on about 900 public and private assistance programs to help patients who need to get access to medicines. And that is MAT, capital M, capital A, capital T.org, and it's free and confidential and easy to use. So in the meantime, our companies are also going into those, trying to penetrate those communities, particularly where they're finding pharmacy deserts, for example, where there are not access to the dispensers of the drug simply aren't in those communities, and trying to identify means by which the medications can get to them. And in fact, listening to some of what Deb was particularly saying, Deb, I'm reminded of what Dr. Jeff Brenner's work was down in Camden, where he talked about what about 5% of the population consumes about 95% of the healthcare spending.
Exactly.
So we've got a lot of disparities on a multitude of levels that we're trying to address here. And in fact, another area that we're particularly involved in, where has a major impact, is in development of clinical trials and getting clinical trial diversity. Because again, if you take that back to the idea that you want to basically enable medications that will in fact address conditions which impact different racial and ethnic groups differently, you need to measure that. And the only way to measure that is through clinical trials. So our companies are investing heavily in efforts to try to expand clinical trial diversity to ensure, and because the disparities are huge with some of the racial and ethnic groups between the percentage of the US population versus their participation in clinical trials. So again, across the board, we're working in this area, working closely with the plans and the providers, because again, everyone has a role, and a very important role to play in this whole effort.
Well, thank you, Dean. So Grace and Nicole, I mean, we just heard from Sure, the provider, on the pharmaceutical side. I mean, from a legal perspective, and again, during our prep call, you know, I mentioned the example where I went out to the prospect and, you know, the employer didn't provide health insurance. But, you know, I don't know who wants to go first, Grace or Nicole, but I'll leave it up to both of you. Oh, Nicole's going to go first. So Nicole, the floor is yours, Nicole.
Thank you, Tony. So now comes the fun discussion about legal stuff. That's always what you're always waiting for. I'm just going to cover some, high level issues that sort of are raised by some of these discussions. So the first one is about the Affordable Care Act, sort of just a refresher, a reminder on the employer mandate provisions. And then I'm just going to discuss some HIPAA issues in terms of the data that may be shared with employers. And then Grace is gonna fill in after me. So first, the Affordable Care Act. So as many of you probably know, there are certain requirements for certain employers to provide health coverage, and it really applies to what are called applicable large employers. They have to offer minimum essential coverage that is affordable and that provides minimum value. So there's a lot of nuance in all of those terms. And if they don't, they basically have to pay a penalty to the IRS. So the determination of what is an applicable large employer, it's based, the current calendar year is based on the prior year. And it's generally employers that have 50 or more full-time employees, including full-time equivalent employees on average during the prior year. So again, there's a great deal of nuance in these regulations. For instance, there are seasonal worker rules. There are employer aggregation rules when you have commonly owned entities or related or affiliated entities that are feeding off of very complicated IRS rules. So, if you're on the borderline, I think the point is, if you're on that borderline of 50, you really, really have to do a very thorough analysis. And as all of this data is showing, even if you're not required to actually offer the coverage, you may want to for very many reasons. So now HIPAA. So there are likely restrictions on the employer's access to their employees' identifying information with respect to healthcare disparities. So to the extent that the employer is really looking into this and wants more information on its employees and what type of coverage they're getting and what types of claims they're submitting, there are going to be restrictions that you have to be aware of. So employers are not subject to HIPAA. They're not covered entities or business associates. You know, HIPAA does have a relatively narrow scope in a lot of ways. However, a group health plan is in itself considered a covered entity. So a group health plan that's sponsored by an employer is going to be a covered entity, is going to have its own distinct obligations. When you have a fully insured situation, most cases, the health insurer is going to actually take care of a lot of those requirements for you. But it's just that I'm just going to point out some things you need to be aware of. So, you know, in terms of how health information is defined under HIPAA or protected health information or PHI, it's really, really broad. So it's basically anything that relates to an individual's healthcare or payment or payment for healthcare. And so there are restrictions on the information that can be shared between the employer or the plan sponsor and the group health plan. And it really comes down to whether the employer is performing plan administration functions. A lot of times they are. A lot of times they have a sort of a self-insured plan where they're going to handle a lot of those functions. So if the employer does handle plan administration functions, they're either going to have to get the employee to provide a written authorization to disclose certain information if they want really, you know, new granular type level of information, or certain protections need to be in place for the group health plan to share the information with the employer. For instance, there has to be a firewall between employees who perform plan administration functions and those who do not. And if the employer doesn't perform plan administration functions, again, unless they get the employee's authorization, you know, a HIPAA compliant authorization to get certain information, the employer is generally going to be limited to very high level, what's called summary health information, and for very limited purposes, for instance, obtaining premium bids. Another layer here is if you offer a wellness program, you know, a lot of this data is sort of, you know, pointing toward this, you know, this greater responsibility that really employers should take to get preventative care and all of those things. Well, if you offer a wellness program, that also potentially has HIPAA implications. If it's offered through the group health plan, then anything that's collected as a result of that wellness program is going to be PHI and subject to HIPAA restrictions. And if it's not a part of the group health plan and the employer is sort of just offering it on its own, just for as an additional benefit, you just have to, you know, it's not going to be subject to HIPAA, the information that's collected, but just to caution you, you may have applicability of other laws, state privacy laws, and that may place restrictions on its use or the safeguards that you have to put in place to protect that information. Generally speaking, health information is sensitive information that's going to have require you to protect it to a greater degree than other information that you have. And so for you know, for assessing these types of issues, you know, the one way you can really sort of stay out of the ambit of HIPAA is getting aggregated, what we call de-identified information. And under HIPAA, you would have to strip that information of a whole host of certain identifiers, essentially, in order to fully de-identify. That's it for me.
Thank you, Nicole. Grace?
Hi, I do want to thank you for letting Nicole and I be part of this exciting and meaningful discussion. It really was eye-opening to hear the, you know, Deb and hear how things are really it is an important issue, and how there are these great innovations and people addressing it. So I'm really thankful to be part of it and learn about it. I'm just segueing from Nicole's reference to wellness programs, and she talked about HIPAA, but one of the legal issues that comes up with wellness programs, if you put them in, is you have to be careful that you comply with other laws. It could be an ERISA plan, so you have to make sure you comply with ERISA, but the other part that there's been challenges to these wellness programs is under discrimination laws, either the ADA law, or there's a genetic anti-discrimination law, Genetic Information Act called GINA. So there have been some challenges to some of these wellness programs under those laws. There was a Yale University case, Questel versus Yale, where Yale University put in a wellness program for its union employees. And there was a class action lawsuit against the program, saying that it discriminated against disability genetic, and asking the big issue with the program that was that they charged really a fee if you opted out of the program. So any of these wellness programs, you have to be very careful that they're voluntary. There's a host of different requirements, but one of them is that it has to be voluntary. Otherwise, it could be viewed as becoming discriminatory. This was under the Yale Expectations Program, it was called. They had the employees, they either had to participate in the wellness program or pay an opt-out fee of $25 a week, which ended up being $1,300 a year annually. So the class action lawsuit was brought by these employees, saying that it discriminated, and there ended up being a settlement. So we don't know how it would have ended up, because it was a settlement where Yale paid $1.29 million to be paid to the employees. And they also changed the way that they shared the information that they found from it. And there were a couple other lawsuits against these wellness programs. There was AARP versus Austin Industries, and that was similar to the Yale University lawsuit, where there was a class action on behalf of the employees of a company called Austin Industries, which was a large construction company, and the EEOC is investigating it. And similar to the Yale case, there was a fee that employees who did not participate in the program had to pay. So in this one, they had to pay an additional premium surcharge of $1,200 to $2,400 per year if they didn't participate in the program. So that is also the case is still out there, but we'll see how that comes out. And then there's another one, Williams versus City of Chicago, where again, there was a wellness program where the argument was that it was involuntary, which would violate the ADA and the GINA. Under that program, the wellness program requested employees and spouses covered under the plan participate in biometric screen and a medical questionnaire. And if they didn't participate, $50 per month on their paycheck would come off. So, I mean, that was sounds like not voluntary, right? So I think the lesson learned is some of these programs, they're really good. You just have to be careful that they don't cross over onto some of these violations and not have penalties for people not participating. There's a lot of guidance out there on how you can do that, whether you can give a gift card if you do participate. I mean, there's various ways to do it the right way, as opposed to doing it a way that it becomes punitive. So that's just, unfortunately, Nicole and I are here to give words of warning when implementing these amazing programs. But the other thing I really wanted to cover was how there are a lot of resources out there on these disparities and how to address it. And there's a couple of studies and articles that there's a McKinsey Industries report. It's income alone may be insufficient, how employers can help advance health equity in the workplace. So I'll send the links to these so that if anybody wants them, they can have the information. But a really interesting article was Harvard Business Review published an article in February of 2023. Employers can do more to advance health equity. the article was really interesting and helpful. And I think that as I went through it, it does seem like what United is doing and what Deb is doing and what Dean is doing is almost exactly what the article is. They didn't read the article, they didn't follow it, but they actually, all of the opportunities set forth in that article, it sounds like they hit on really all of them. That article explains why employers should find solutions and that they should showcase companies innovating in this space. And I really think that United and Bergen and they really are should be showcased for what they're doing. It really what it said here is 55% of people in the US receive health coverage and benefits such as wellness on-site clinics through their employers, right? So how do we make sure that it's covering all these things? And I think that the various opportunities, one opportunity is optimize benefits and health plan offerings, expand primary care and mental health across virtual care and community partnerships. Those are exactly the things that Deb said that they're doing through their hospital. Expand primary care and mental health. She has the ShopRite innovation, the community outreach and mental health. So I think we can learn lessons from them. And even United, I don't mean to because I actually have United Health. I didn't talk to Paul about this before, but it really is true that there's a lot of outreach programs and emails that you get about things you could participate in that would really try to address the disparities that go beyond just signing up for the health insurance. Paul and I didn't talk about this. He doesn't even know I have United Healthcare, but I do think that United Healthcare and Newbridge are really setting examples, and the fact that they're sharing it here for other people to maybe copy it and do something similar. I think that's excellent. So there's this Harvard Business Review article. There's McKinsey. And another suggestion is make benefits easy to navigate. It certainly sounds like Paul's program, having all these access for people to get to the prescription program. Another example that really falls within the suggestions in these various articles. And another important aspect of it is the collecting of data. So I think even on a little level, employers can check their absentee levels. They can check problems with not affording co-pays. There are various ways to collect data on a large and a small level. There are some tools for collecting data. Medicare has a worksheet for a screening tool for really assessing social disparities and social information. There's also the American Hospital Organization has a healthcare disparities toolkit. So there are a lot of resources out there for people who are looking to really do a deeper dive and see how it would work for them and their program. Like I said, the article and the suggestions, it really does seem like you can do something about it, and there are organizations doing things about it. And it's like I said, I really think it's great to be part of this this discussion, and hopefully it'll keep moving forward. And I'm ending there.
No, thank you, Grace. We have a few more minutes, so let's open it up to any questions from anyone. We could use the chat. You can unmute and ask the question. Anybody?
Hey, Paul, I actually have a question. I'm just wondering if you do get interest from the plan sponsors for information and what you do share with them.
We do. We get a lot of interest. As a matter of fact, a lot of what we've developed has come at the request of employer groups. There's a huge correlation between workplace productivity and members' health. We've done studies with a number of different national account clients, as well as some of our mid-market. But one that jumps out is a major airline. We measure the actual health of the population in terms of their utilization statistics. Are they taking advantage of wellness programs? Are they engaged? Universally, we compare cities for that airline, and the cities that have a healthier population have less delays. They have less bags that are lost. They have, just in general, we synced up all their productivity measures that they look at, measuring their population versus the health of that population across 60 different categories. And we index it, and there's absolutely a correlation. Those locations with lower scores on the health index have worse performance in the business. And so, you know, when you look at health equity, if you have a population for an employer that resides in a zip code that generally is underserved, generally what you're going to see is worse health outcomes. And again, it impacts the productivity. So they are asking for it. That's why, you know, and we've seen it across our Medicaid and Medicare businesses as well. Bottom line, it's just good for everybody. It's good for the businesses, commercial insurance, to try and address people who aren't getting what they need. It's good for the community, because if we can address those folks in New Jersey, for example, that aren't getting the care that they need in Medicare or Medicaid, they end up at the ER, there's uncompensated care, that goes into our tax base. It goes into higher premiums for the commercial because of cost shifting. So it's just good for everybody, and employers are increasingly interested. And we've got to do a better job reaching out to them to get more information from them on income and ethnicity voluntarily submitted in, so that we can start drawing those correlations, but increasing interest because the benefits are so great.
Thank you, Paul. I think, Dean, you had a comment, Dean?
Yeah, just in terms of getting back to the issue of the adherence and compliance, you know, one of the other things that's happened is looking at the diagnostic side of our industry, the med device side, they've come up with some extraordinary diagnostic tools. You see a lot of them advertised on TV, but their whole point is it enables monitoring of patients' conditions remotely, which is a major element here in terms of, for example, diabetes or any of the chronic conditions, diabetes, congestive heart failure, asthma, to name several. So again, I know that there's a byplay there with some of the legal considerations with information sharing and data gathering and the like. But at the same time, the more we can arm, if you will, the patient population, wherever they may be, with these kinds of devices, so that the plans and the providers can ensure that patients are doing what they should be doing in areas that they can help themselves, that can advance the agenda a long way in terms of keeping patients healthier, irrespective of barriers that exist culturally and socially and economically.
Thank you, Dean. Any other questions, comments?
Hey, Tony, I'll just, if there's not quite, just a quick plug. I would urge employers to look at your health insurance plans and really honestly assess, thinking about 60% of Americans can't afford $1,000 of unexpected expense. There are alternatives out there to lower the out-of-pocket burden for your employee population. There's various products out there. I would urge you to talk to your insurance broker or your carrier about some of the products that are now available that drastically reduce the out-of-pocket expense for employees, because they do exist, and it is vital to enable those folks who can't afford it to get the care that they need.
Yeah, no, thank you, Paul. That's important. Just a comment I was going to make, Deb, you mentioned about going out to community. There's a bill going through Trenton called the Hospital at Home Act, which is kind of interesting that, you know, I guess the mentality out there is let's change the way we've been doing things, right? And maybe patients can coalesce at home. I thought that was an interesting bill, and just kind of hearing the testimony there.
Yeah, no, that's a really important bill for, you know, as care moves out from the walls of the hospital into communities, into the homes,
Yeah.
the elderly population that can't get out of their homes and being able to deliver care right into their homes through programs like the PACE program. The other thing I just, in conclusion of what I talked about before is, talking about equitable access to healthcare. One of the things that, we really hold firm to is trust and, assuring that communities trust us and the delivery, us as healthcare providers and us as their beacon of health and hope and education. And so I think that's a huge factor in assuring that people, get the care they need when and where they need it.
Thank you, Deb.
Thanks.
All right. It's approaching 10 o'clock. The hour went fast. So I want to thank all of our panelists, and I want to thank all of you for being here today. Stay healthy, enjoy summer, and we'll hope to see everybody on at our next event, whether it's in person or virtually. So thank you, everybody.
Thanks.
Take care.
Bye, thank
Have a
you.
great day.
Take
Take care.